Burns. The priority concepts are going to be tissue integrity, fluid and electrolyte balance, perfusion, and gas exchange, with interrelated concepts being nutrition, comfort, and mobility. Burn injuries can be chemical, electrical, radiation, smoke-related, the inhalation injury, or thermal, which is heat-related. Excuse me. The cause affects the prognosis of the client and the treatment. It can be minor to life-threatening. Not only is tissue integrity lost, but the function of numerous body systems can also be changed when the skin is injured. The types of burns or etiology of burns can be chemical, contact, electrical, fire, which includes flash and flame, radiation, and scald. With chemical burns, these can occur in the home, manufacturing areas, can be from an assault, etc. The injury will be dependent on the duration of the contact of the chemical, the concentration of the chemical, the amount of tissue that's exposed, and the chemical's action. And some chemicals can cause a systemic effect. Contact burns are from contact with hot metal, tar, or grease. Electrical burns travel through the body. They have an entry and an exit wound, and they have what we call an iceberg effect. In other words, we just see a small area of injury, but there can be a lot of internal damage uh, due to the electricity bouncing around inside the body before it exits. The electrical burn is also dependent on the type of current, the pathway of the current, the local tissue resistance, and the duration of contact. With fire burns, again, we have the inhalation injury. Orofacial burns can cause edema that impairs breathing. So we always should be assessing the mouth, the throat, and the nose for soot, and listen for coughing, shortness of breath, or hoarseness to help depict potential inhalation injury. Exposure to open flame and explosions, those flash burns that produce a brief exposure, but they're to very high temperatures, can cause what we call dry heat injuries. Radiation burns occur with prolonged exposure to the sun or sources of radiation, whether it's X-ray or from the nuclear industry. Scald injuries are caused by exposure to steam, hot liquids, or hot grease. Spills usually involve the chest or the arms. Immersion will usually involve the legs. Hot grease burns are usually deep due to the high temperatures of that grease. Burns are a leading cause of unintentional death and injury worldwide. The extent of a client's burn injury will be related to their age, their general health, the size and the depth of the burn, and the specific body area that's injured. These injuries can cause complications even after healing, such as contracture formation and scarring. Skin changes can result from burn injuries, where we have anatomic changes. If that dermis is present with the burn, that skin can regrow, but when the entire dermal layer is burned, all cells and dermal appendages are destroyed, and the skin can no longer regrow. And if the burn is deep enough, it can involve subcutaneous tissue, bone, tendon, and muscles. We may see functional changes. We know that the normal functions of the skin provide a protective barrier against injury and microbial invasion, maintains normal body temperature, activates vitamin D when it's exposed to the sun, helps maintain fluid and electrolyte balance, and helps provide that sensory perception from pain, pressure, and touch. But burns can change the function, allowing for infection, hypothermia, and hypovolemia. We also see some psychosocial changes with reduced self-concept. Burns are classified depending on the severity, and that severity is determined by how much body surface is involved, as well as the depth. The quickest method to determine the extent of the burn injury is what we call the rule of nines. But be aware there is a different rule of nines with the infant, child, and adult. And in this case, we're talking about the adult. If the burn is smaller, the client's palm size equals about 1% of the body area. If we want a more accurate determination of the amount of body surface area burned, we use tools such as the Lund and Browder method. Those would be more appropriate for the burn unit. Again, burns are classified by the depth of the tissue destruction, and the amount of tissue destruction will be dependent on the agent causing the burn, the temperature of the heat source, and how long that skin was exposed to it. There are two primary classification systems. We look at the degree of burn, which would be first, second, third, and fourth, and the degree of thickness, which would be superficial or deep. Differences in the skin thickness in various parts of our body can also be a factor. For example, if you look at your ankle, we have a very thin skin thickness there versus if we look at the thigh. Burns can also be classified as minor, moderate, or major. So look at that table that's in your textbook. Superficial thickness. We have the superficial first degree, where the damage is going to be above the basal layer of the epidermis. The skin or burns are dry, and they're pink to red in appearance, and they are very painful. They do heal in about a week. The superficial second degree, we have damage down into the dermis. The burn appears moist, red. There may be blanching and or blistering. Excuse me. We have mild to moderate edema and significant pain, and it takes about 2 weeks for these to heal. With deep thickness, we have a deep second degree or deep partial thickness where the damage is deep into the dermis. It's less moist, less blanching, there's moderate edema, rare blistering, and it's less painful because now we're starting to get into some of the nerves. There may be some soft or dry eschar. It may require some grafting, and it usually takes about 2 to 6 weeks to heal. The third degree burn, or full thickness, the damage is going to be through the entire thickness of the skin into the fat, and it can appear any color: black, red, yellow, brown, white. There's going to be severe edema. The eschar will be very hard and inelastic. In other words, has no give to it at all. And again, no pain because it's now into the nerves. It does require grafting and heals in weeks to months. And then finally, the fourth degree burn, where the damage extends into the muscle, tendon, and bone. These burns are black, severe edema. There is eschar and, again, no pain. Grafting is ineffective and it does require specialized care. It will heal in weeks to months if it heals at all. This is the typical appearance of a superficial partial thickness burn injury. The typical appearance of a deep partial thickness burn injury. And this is going to be a full thickness burn. A deep full thickness burn. It's very important as we begin to care for these clients to get a history. We need the source and cause of the injury, including any other potential injuries. We need to know what care has already been provided, the client's age, their weight, and their height. We also need to know immunization and medical history. Clients who receive significant burns will require a tetanus shot if they are due, if it's been at least 5 years. We're going to begin our assessment by looking at the skin for the size and depth of injury, and we're going to get a percentage of total body surface area that is affected. It's always the priority to look at the airway, even in clients that may not appear as if they've experienced a severe burn. Inhalation injury can occur even without integumentary burns and may require an artificial airway. It is most critical to prevent those life-threatening complications for those who have inhalation injuries. So, even with minor burns, it's important for us to assess the mouth, the nose, and the pharynx. And continuous assessment would be a priority. We may not see any symptoms immediately, but they may develop later on. We should be assessing for drooling, difficulty or frequent swallowing, hoarseness, a cough, stridor, wheezes, the intraoral charcoal or soot, the singed scalp or facial hair, sputum with soot, use of the accessory muscles to breathe, edema or erythema or ulcers of the airway mucosa, facial burns, and changes in the vital signs or decreased oxygen saturation. All of those can be indications of inhalation injury. We also need to be concerned about carbon monoxide and cyanide poisoning with inhalation injuries. Histamine or other inflammatory mediators with inhalation injuries are going to cause capillaries to leak fluid into pulmonary tissue space, and this can also lead to potential pulmonary edema or pulmonary fluid overload. And in the acute phase of burns, pneumonia can occur. With the cardiac system, we're looking at potentially hypovolemic shock, which is a common cause of death in the early phase of clients who have serious burn injuries. Decreased cardiac output that may require invasive blood pressure monitoring in clients that have large burns to the upper extremities. Vital signs are always going to be a very good indicator of client status. The cardiac rhythm, especially in cases of electrical burn injuries, should be monitored for arrhythmias. We should also do an immune assessment. These clients have an increased risk of infection, and sepsis is a serious complication of burn injuries. So we should continually assess for signs and symptoms of infection, including changes in the wound appearance, the neurological and GI function, and subtle changes in the vital signs. With the musculoskeletal system, as that burn injury client is at an increased risk for musculoskeletal and mobility issues, it does require frequent assessment of joint range of motion. Metabolic changes. For the first 48 hours post-burn injury, we've got a decrease in cardiac output, oxygen consumption, and our metabolic rate. Then hypermetabolism about 5 days post-burn injury is going to be noted, and we have an increase in our blood pressure, our heart rate, the peripheral insulin resistance, and protein and lipid catabolism. This also causes increased body temperature, increased protein loss, and muscle wasting. And we have impaired glucose tolerance, and hyperglycemia is common. With the kidneys and the urinary assessment, there might not be any issues with the less serious burn injuries, but we may see a decreased urine output because of those fluid shifts. Due to destroyed red blood cells, muscle damage, and resulting release of proteins that will form uric acid, this can create a sludge that can start to block those renal blood vessels and the urine flow, leading to renal failure. With gastrointestinal changes, again, in less severe burns, there's no symptoms unless there's potential GI upset. We may see decreased blood flow and sympathetic stimulation during the early phase, causing a reduced GI motility or paralytic ileus. So it's very important to assess for bowel sounds, nausea, vomiting, and abdominal distension. It's also important to realize that in burns over 25% of total body surface area involved, or those clients who are intubated, they may require a nasogastric tube. And Curling's ulcer can occur in clients that have extensive burns. We're going to look at some labs, and our blood studies would be elevated due to that fluid volume loss. Glucose would be elevated because of the stress response and altered uptake. Sodium will be decreased due to trapping in the edema fluid and loss of plasma. Potassium is elevated due to disruption of the sodium-potassium pump. Protein is low, so we need to monitor our baseline readings and routinely afterwards to help monitor the client's overall status. Priority collaborative problems for clients that have burn injuries include impaired gas exchange, impaired fluid and electrolyte balance, compromised tissue integrity, potential for infection, pain, decreased mobility, decreased self-esteem, and some age-related concerns. With our older adult, they've got thinner skin, so that can increase the depth of the injury. They may have sensory impairment, which increases the risk of burn injury. They may have decreased mobility, which also increases the risk of burn injury. They have a slower healing time, which can increase the risk for infection, contracture formation, and scar tissue. And they may have decreased inflammatory and immune responses, which also increases the risk for infection. And remember that older adults may not have a fever with infection. And finally, they may have an increased potential for comorbidities, and those comorbidities might interfere with wound healing. This is your rule of nines, and we have the adult, the child, and the infant, so you can see the differences in how we determine the total body surface area burned. And now the Parkland formula. So the Parkland formula is going to be used to help determine the total fluid requirement in the 24 hours after the burn occurs. So we're going to give 4 millimeters of fluid multiplied by the total body surface area burned, that percentage. Now we're not multiplying percent, we're multiplying the number. So let's say it's 27, we would not multiply 0.27, we would multiply 27, multiplied by the body weight in kilograms. We're going to give half of that fluid. So once we get the total from number 1, we're going to divide it in half, and we're going to give half of it in the first 8 hours. And then we'll give the remaining half over the remaining 16 hours. Interprofessional collaborative care is care that occurs in the first hour after a burn injury, and it can make the difference between life and death. There are 3 phases of burn care: emergent, or the resuscitation; acute, or the healing; and rehabilitative, or restorative. In the emergent or resuscitation phase, this is going to begin at the onset of injury, and it will continue for about 24 to 48 hours. Priorities are to secure the airway, support the circulation and perfusion, maintain the client's body temperature, keep the client comfortable with analgesics, and provide emotional support. We do this by determining the extent of the burn and other injuries, prevent or treat respiratory compromise, shock, and/or hypovolemia, perform initial wound assessment, provide initial burn management interventions, and the tetanus shot if none has been given within the last 5 years. In the acute or healing phase, this will begin about 36 to 48 hours after the injury, when that fluid shift has resolved, and it will last until wound closure is complete. We do focus at this phase on continual assessment and maintenance of the cardiovascular and respiratory systems, the nutritional status, wound care, pain, and psychosocial interventions. We do this by preventing or treating infection, providing wound care, preventing local and systemic complications, providing ongoing nutrition and metabolic support. In the rehabilitation or restorative phase, this begins on admission, but the technical part of the phase begins with wound closure and ends when the client returns to the highest possible level of functioning. The emphasis will be on psychosocial adjustment, prevention of scars and contractures, and resumption of pre-burn activity. This phase can last years or even a lifetime if a client needs to adjust to permanent limitations. We do this by preventing contractures, continuing wound care as needed, support physical recovery and return of optimal function, providing professional emotional support, and encouraging a consult as needed. So let's look at the emergency management of burns. With every burn, we should always assess for airway patency first, administer oxygen if needed, cover the client with a clean, dry sheet, elevate extremities, initiate the IV, and begin fluid resuscitation. More specifically, with chemical burns, we need to brush off any dry chemicals on the skin or clothing and make sure you do it safely so you have gloves on, um, making sure that you're not brushing it onto yourself, etc. Remove the client's clothing, but don't get it wet. Some chemicals are activated by moisture. Determine the type of chemical. Don't neutralize the chemical until positive identification has been made of the substance and we have the appropriate neutralizing agent available. With electrical burns, we need to initiate and continue CPR as needed. Make sure you get that ECG. With fire, whether it's flash, flame, or scald, remove any smoldering clothing and all metal objects. Remove jewelry that may become constraining. Cool the burn with cool water for at least 5 minutes, but don't allow the client to begin shivering. With radiation burns, remove the client's clothing. Use tongs or lead protective gloves to do it so you're not contaminating yourself. You're going to assist the client to the appropriate decontamination center and assist with showering as needed. So let's look at some specific interventions. With the acute phase, these clients require frequent monitoring. We need to maintain their airway, and that may require an artificial airway and or mechanical ventilation, oxygen therapy, fluid replacement, and this will be IV fluids, definitely I's and O's. We want to see at least 30 to 50 mLs per hour, and an indwelling urinary catheter. Remove clothing and jewelry. Prevent infection, and this is where we cover them with that dry, sterile blanket. Prevent hypothermia. Administer analgesics. With severe burns, we will transfer them to the burn center. They may require antimicrobial ointments and or creams, compression garments. We need to monitor labs. With wound care, we need to maybe use standard wound dressings. We can use biologic dressings. The homograft would be human skin. Heterograft would be skin from other species. Frequently, pigs are going to be very comparable to the human composition. Amniotic membrane, cultured skin, or artificial skin. We can also do biosynthetic dressings or synthetic dressings. We can do mechanical debridement. This is often done with hydrotherapy or the water. Enzymatic debridement. We have autolysis and collagenase. We can do surgical management. We may need to do a bronchoscopy for airway management, and this would also require some deep suctioning and removal of any necrotic tissue. Surgical excision. We may do skin grafts. We should also educate on health promotion and disease prevention. We teach our clients to always assess the water temperature and encourage them to set their water heaters below 120 degrees. Encourage them to use at least a 30 SPF sunscreen and wear protective clothing when out in the sun. Never add flammable substances to an open flame. Never smoke in bed, especially when drinking alcohol or taking drugs that may cause drowsiness. Install smoke detectors and carbon monoxide detectors and check those batteries routinely. The rule of thumb is with the time changes, you change the batteries. Use space heaters with caution. These are a frequent cause of home fires, and keep flammable objects away from them. Keep matches and lighters out of the reach of children or cognitively impaired adults. Use screens with fireplaces and have the chimneys swept annually. That creosote can build up on the interior chimney and it is highly flammable and burns very hot and very difficult to put out. And finally, plan an escape route from burning buildings. A couple of the surgical procedures that may be required would be an escharotomy or a fasciotomy. So on the left side, we have the escharotomy. This is where the burn tissue, we have so much edema that the tissue can no longer expand, so we cut incisions to allow for further edema. In the same way with the fasciotomy, we just have so much edema going on that we have to allow for additional edema, uh, or we're going to have neurovascular compromises, a loss of circulation or nerve function. A client arrives to the ED with superficial facial burns from an explosion. The client has productive carbonaceous sputum with labored respirations and singed facial hair. Based on these findings, what is the highest priority of care for this client? This client obviously has some respiratory issues, so we're talking inhalation injury. The primary concern is going to be that airway. Which symptoms does the nurse recognize that may indicate a pulmonary injury from the inhalation? Select all that apply. Development of a brassy cough, drooling, clear speech, audible wheeze, clear breath sounds. The correct answers are A, B, and D. 20 minutes later, assessment of the client reveals loud wheezing on exhalation. What is the nurse's best action at this time? Check the client's SaO2 with pulse oximetry. Apply oxygen and call the rapid response team. Call a code and bring the crash cart to the room. Call respiratory therapy for bronchodilator treatment. The correct answer is B. We've had a client who has what we are pretty sure is inhalation injury. If we start having that wheezing or stridor, the client could be very close to losing their airway. We need to get oxygen on them and we need to get some help there quickly. We need to intubate them before that airway becomes completely obstructed by edema. The nurse is caring for a client who's admitted to the ED with burns to the lower legs and hands. During the initial management, what is the priority nursing care? Assess and treat pain, evaluate airway and circulation, place 2 IV catheters and initiate fluid resuscitation, use the rule of nines to estimate the percentage of body surface area burned. The correct answer is B. It's been 12 hours since a client has been admitted for burns to the face, neck, and associated inhalation injuries. Excuse me. The client had been wheezing audibly and the wheezing has now stopped. What nursing action is appropriate? Check the client's SpO2 level. Notify the provider immediately. Reassess breathing in 1 hour. Document improvement in the client's condition. The correct answer is B. We have a client who has an inhalation injury and now they're becoming more breathless or the audible respiratory sounds disappear, could indicate a worsening of the client's respiratory injuries, including possible loss of the airway. A client has been receiving dressing changes with silver sulfadiazine for burn injuries over both lower arms. The nurse notices the client's white blood cell count has dropped significantly over the past 4 days. How does the nurse interpret this finding? We have an electrolyte imbalance. Infection is improving. We have impending kidney disease. Or we have a possible allergic reaction to silver sulfadiazine. The correct answer is D. It can cause a drop in the white blood cell, indicating an allergic reaction. It does not cause kidney disease, infection, or electrolyte imbalances.